So, to start with, I have a case before you there. This lady was 33 years old when she came to us. Oops, this thing is moving itself. This is a 33-year-old lady who came to us when she was Part1, gravid 2 then. And she was referred to us when she was 23 weeks and 2 days, but she presented it 4 days later when she was 23 weeks and 6. This lady, she booked with a private gynecologist and she never had a first trimester aneuploid screening. Yes, she was sent for an anomaly scan by her doctor when she booked in. And the scan which was done showed that the baby had ventriculomegaly from a private, from a sonographer. And the patient was referred to us for second opinion assessment of the baby. So what you are seeing on the screen there are the biometric parameters. On your own, kindly interpret the biometric parameters you see there. Maybe you can just send a message on the chat box in terms of what you are seeing just on the biometric parameters. I'll just give you 30 seconds to look carefully at the trend there. When we measured the baby's parameters, this is what we saw. This is what we saw when we measured. This is what we found out, that the baby was not growing well, but what is wrong with the growth? Maybe this is where we want you to just send a message on the chat box so that we can all appreciate how people are thinking. Check the clinical reasoning component. Or what do you think is going on the growth there? You can see the charts, you can see where the femur is, where the AC is, and where the head is. Please type your response. I'm just hoping that everyone can type their response, Thelma. Is Thelma even in the meeting? Maybe I'm referring to somebody who's not even in the meeting.
I'm in the meeting, Dr. Verenga. It's a meeting, so anyone can type.
Okay, thank you.
And they can unmute themselves as well.
Okay, thank you. So please just type what you think on the growth so that you can quickly move on. I just want to see the line of thinking because you may measure a baby like this one and you have to figure out what is going on. So this is the image we are getting. We're trying to, it's not an image of the head circumference. Maybe the head circumference image will come, but this is the image that is coming out of the baby's head. Withhold what you are thinking. If you have it, you can write what you are thinking in the chat box as well. But this is what we got when we tried to image the baby's head. I'll move on to the next picture. And these are the eyes. Please type in what you think when you look at these images. What is going on? The baby was a little bit stubborn. We couldn't get the baby to face upwards. So we took the baby from when it was looking sideways, and these are the orbits. Here we're measuring the intra-orbital distance here, and then the interorbital. These are the measurements you see there. So the first one, the first was what? Was we had the first was the intraorbital distance, and these two are the intraorbital distances. That is the distance within the eyes, and the first one was the distance between the eyes. Again, type what you think in the chat box so that you can see how you are thinking. This is the face here. Again, type what you think of the face. When you look at the face on the side, what do you think of the face of the baby? So that's the face here. You can see that's the forehead. This is the nasal bone, the lips, not looking nice, the face. Again, this is the face again. Just focus on this image. This is the face. Let me put a pointer. So this is the face, yeah. Again, type what you think on the face, on the chat box. I don't know if people are sending what they are typing on the chat box because I don't see anything yet. The volume is low. People can't hear me or what? I think that was before we started, right? So kindly type your response and send on the chat box. Then the next image, I think the image of this baby end here. The question now is, what is going on? What is wrong with this pregnancy? Again, please type what you think and share it on the chat box. I'll just wait a minute to just see what people think, and then we'll go back and rediscuss all the images. The rest of the images were, let me say, were unremarkable. That is the spine, the extremities, and the kidneys, they were there, and also the heart appeared normal. Sorry, the heart, there was the heart asymmetry with a small left side. So probably there was some aortic stenosis here. So the heart was abnormal. I'm sorry I didn't put the images of the heart. Yeah. Type what you think. If you think what you have seen is associated with the syndrome, again, type the kind of syndrome you think is underlying the defect that you just saw. I don't see any message in the chat box. Are people able to type or what? Hello guys, can you hear me or not?
I can hear you, Dr. Verenga. I cannot type, but maybe I'll try. I'll give a try verbal.
Okay. Then you can go ahead and give your verbal try of what is going on or the images that you saw.
Okay. From the images I saw, the biometry. From the biometry, I think the estimated fetal weight and circumference are on the lower end of the centiles, although they are not below the 10th. although they are not below the 10th centile, they are on the lower end. The femur and abdomen seems okay, but weight and head circumference are on the lower end, maybe around the 10th centile.
If you look at these nomograms represent 3rd and 97th centile.
Oh, all right, that's
so. Yeah, so they are around the 3rd centile.
Okay, I thought it's the 10th. Okay, if it's the 3rd, then the weight and the head circumference are definitely low. Femur length and abdomen may be okay, but weight and head circumference are probably below the 10th centile. They are below the 10th centile, between the 3rd and the 10th centile. Then on the head.
So what do you think? What do you think is going on?
There is this is a small baby, SGA, or a growth restricted baby.
All right.
Either SGA or a growth restricted baby. Then
it's a small baby. That's correct. But when you now look at the causes of smallness, what goes through your mind?
It could be constitutionally small, or it could be growth restricted.
Right. I like the answers you gave there. I think those are the basis of teaching from this slide, to say the moment you measure a baby, and the femur is okay, even if the femur may be short, right? But the tummy seems to be okay. It's not as small as you would expect in a placenta insufficient case, but you have a small head. Then you now know that you're no longer dealing with the classical fetal growth restriction here, but you are more likely leaning towards chromosomally abnormal babies.
Okay.
The baby's head should never be small. As long as it is small, it cannot be normal. Small baby and chromosome abnormality or genetic syndrome, probably a small head and chromosome abnormality and genetic syndromes go hand in hand if the head is that small. So the moment you have this kind of a picture, you can't label this baby as fetal growth restriction, because certainly there is an abnormality which suggests that there is an underlying chromosome abnormality. Remember, the other definition of fetal growth restriction is that the baby should be chromosomally normal and there should be no defects on the baby. The moment there are defects, it's no longer the classical fetal growth restriction that you are used to, where you know that there's the placenta which is not feeding the baby and is starving the baby's liver, because the classical placenta insufficiency condition will give you a small tummy, not a small head. A small head is not the first presentation. Small head with very narrow interorbital distance, a flat nasal bone, no development of the anterior fossa structure. That's Dr. Lacha, very good observation there. Yeah, so the issue here is with a small baby. Let's call it a small baby syndrome for now. There is no syndrome like that, but let's a small head syndrome. We will go on with the picture to try and say what is causing the small head. Now, so the next photo, the next image which you showed you.
Sorry, Dr. Verenga.
Yes.
This patient been previously scanned, or this was the first scan. I'm asking with respect to dating. Had she been previously dated, or this is the first scan?
Let me say the dates were validated for this pregnancy.
Okay.
Yeah, we validated the dates. The patient who came to us as a referral for ventriculomegaly.
Okay.
And we managed to validate the dates for her. So yeah, so in this case, let me say the dates are validated for this case. That means the dates, what you are seeing on the charts represent where the baby is in terms of growth. Right, so if I go on to the next one, so when you look at this image now, pattern recognition is very important in ultrasound. You have scanned babies a lot of time, and you know that when you image the baby's head, you are supposed to see a midline. The midline should always be seen. The moment you don't see the midline, there are only two conditions that will make the baby's midline disappear. One, it is hydranencephaly. Hydranencephaly means there is total evisceration of the baby's brain due to some obstruction at the internal carotidary base, and there's no brain at all. All you see in the baby's head is fluid and no brain tissue whatsoever. The second condition is holoprosencephaly. So in this case, you can see that there's no midline, but what we are seeing is a monoventricle here. That's a monoventricle. You see one ventricle, because the baby's brain, if you remember from our neurology lectures, that failure to divide, failure of the brain to divide will lead to a monoventricle. So that's the monoventricle we are looking at there. I think there are some new sisters at Part. I'm not sure if they were added into the group, Thelma. Please check. They may not be aware that we're having a meeting actually. So this is the monoventricle here. And what we are seeing now is the more like a fusion of the thalamides and the cerebral peduncles here, and the cerebellum, the posterior fossa, which appears to be intact. So this is a case of holoprosencephaly. More for aloba holoprosencephaly. We go on with the images. The hypotelorism. Dr. Lasha pointed out there that the eyes are too close to each other. How do you know that the eyes are too close to each other? When you measure the intraorbital distance, the interorbital distance should be the same as the intraorbital distance. Because grossly, you should be able to fit another orbit in between the two eyes. But if you cannot fit another orbit, then you know that the eyes are too close to each other. And that becomes hypotelorism. So there is hypotelorism. Indeed, the face is flat. You can see that there's some interruption happening at the level of the face. There is not a clean face. Then when you look carefully, we now see a cleft. This is the portion of the lips. I'm sorry, the image is not as clear as it should be, but you can see that the upper lip is not continuous. This is the upper lip which is interrupted here by this gap. This was quite a large gap here. So that is a cleft lip. There was a cleft lip and palate. I'm sorry I didn't put the image of the palate there. So what did we have? The case was referred to us as ventriculomegaly, but in this case we had the holoprosencephaly with a mid-fascial defects. In this case, we didn't have a proboscis. We had some nose. We didn't have a proboscis. Sometimes we have a proboscis in the aloba case. So the moral of the lesson is you should know how to recognize the pattern. Ventriculomegaly should give you a midline. If you don't have a midline, it cannot be ventriculomegaly. So remember the two conditions that will make you miss the midline at all. At the hydroencephaly, where the whole brain is wiped out, all you see there in the brain is fluid. The second one is holoprosencephaly. Between the two, in our series, holoprosencephaly is the most commonest. So remember your patterns, pattern recognition. What is the importance of distinguishing the two conditions? Because they have different outcomes. You know, there are babies with holoprosencephaly who walk up and down the streets of Harare with their shanks, but you will never meet an aloba holoprosencephaly anywhere in the world because the condition is lethal. If you tell a woman that you've got ventriculomegaly, when in actual fact they have holoprosencephaly, you give them some hope. And they will think that their baby will be born, their baby will be operated on, and probably will have a shunt, and you know. But aloba is a totally different whole animal, and it is lethal. What happened to this case? Unfortunately, when you put everything together, we thought the baby it most likely trisomy 13 because we also had a heart defect, like I told you, that there was also a heart defect because trisomy 13 exists in about 50% of babies with holoprosencephaly. Mostly there are other defects like the heart defect and so forth. Trisomy 13 is the likely underlying condition. More so if the head is small head, all those things, the mid-fascial defects and the cardiac defect. So we thought the baby had trisomy 13. Unfortunately, the couple didn't afford amniocentesis. They didn't do it. They went on to terminate the pregnancy for this case. So that is the summary of the case. The aloba holoprosencephaly, we discussed this case. The holoprosencephaly is in our neuro series. You can always go back to YouTube channel and learn more about the case. But the most important thing is for you to be able to recognize it because the outcome is totally different from ventriculomegaly. Like in this case where the couple were referred to us thinking that they've got ventriculomegaly. Right, so that's case number one. Case number two. I'm going to narrate to you the background of case number two. This is the case of this beautiful baby there. So case number two is that of 34-year-old lady who was referred to us at 36 weeks of gestation. This was her third pregnancy with one baby at home and a previous miscarriage, and a previous early neonatal death, an unfortunate one due to birth asphyxia. In this pregnancy, again, aneuploid screen was not done. She booked with a private gynecologist very late, and she had an anomaly scan, which then was reported as normal. But then she had a scan, a third trimester scan, which showed that there was ventriculomegaly. So again, she was referred to us for a second opinion for the diagnosis of ventriculomegaly. So this was the baby here. So this is the growth of the baby. Does anyone want to comment on the growth? Does anyone want to comment? This is the growth. I'll give us a minute to comment on the growth. Any comments on the growth?
I think what is striking there is a short femur, and weight is also probably on the low end, around between the 10th and 3rd and 10th center. Otherwise, the abdomen and the head, although below the 50th center, may be okay.
Great observation. So short femur. So short femur and small head, again, are signs that you should look for something. We are not dealing with a classical placenta insufficiency case here because the tummy is growing. If the tummy is growing, you can't be talking of a placenta insufficiency case. This is very important to all of us to understand this because I think with the placenta disorder clinic, I think of late there is a patient I was asked to see again at Verenga fetal defense clinic who was being followed up in the placenta disorder clinic, whereby the baby has not been growing, and we now think the baby has got trisomy 18. If we see a baby whose tummy is normal and the other parameters are small, please don't continue following up that baby in the placenta disorder clinic. It's not a placenta disorder patient. That's not fetal growth restriction by the classical definition where there has to be no abnormality. That case is a fetal defect case because there could be something underlying on the baby. So please get this right, that if you see a baby whose tummy is measuring normal, but somehow the tummy, the femur is too short or the head is too small, do not continue seeing the patient in the placenta disorder clinic. It's a fetal defect clinic case. Refer to the fetal defects clinic for assessment. So you are right that the femur is abnormal. So that's a cause to examine the baby to say what is going on. Why is the femur small? Remember the referral diagnosis. Always keep it in mind. So this is the image of the baby. What is the comment? You can see the head circumference. Any comments on the head? And anything you see on the head there, what is the comment? Ventriculomegaly present, yes or no? Ventriculomegaly present, yes or no? Please type. Yes, ventriculomegaly is present. All right, I'll move on. What else can you see? Look carefully. I'll move on. I'll not divulge what else is there. I'll move on, then we'll come back to the after. I'm calling the images. We're still on the head. Look at the images of the head. Look at the images of the head. What else can you see? The midline isn't clearly outlined. Fine, Marcel. Yeah, right. In this case, the midline is distorted. We can't say clearly. Was here we can see that the midline is there, but we agree that you can see the midline is there, but it's a distorted midline. There's something else distorting the midline here, which we'll find out from you guys. You can see there's a structure pushing the midline, a C6 structure there. All right. What else can you see still on the head? That's on the brain still. right? So I'll move on to the next one. This is the posterior fossa, probably fairly intact, but you can still see the brain there. Let me move on to the next one. Dopplers, that's the umbilical artery Doppler. Nothing remarkable on the Doppler. That's the ductus venosus. For probably for 36 weeks, so reduce the A wave there. Borderline high PI. Then this is the heart. I'm sorry to say my image of the heart is not as clear as it should be, but they seem to be cardiomegaly, yeah. On the image. There was cardiomegaly from our assessment of the baby. Now this is the image of the head again. Yeah, ventricles are dilated, you're right, Maxwell there. And now this is the image of the head. After putting on the color, MCA could not be obtained in this case. So the question now is, do I still have more? No. The question now is, what is the diagnosis? What is the diagnosis? Any takers on the diagnosis? Probably severe ventriculomegaly, not quite there. Yes, there is secondary ventriculomegaly, correct. There is secondary severe ventriculomegaly, but what is the primary cause? What is the diagnosis? Any takers? Right, so I'll go back to the first image so that we can explain what's going on. It is correct to say there is ventriculomegaly, but the ventriculomegaly we are looking at here is a secondary ventriculomegaly. The cystic structure we are seeing here is a dilated vein of Galen aneurysm. So this is a vein of Galen aneurysm, which is compressing the ventricular system, giving us the secondary ventriculomegaly we see, and also the destruction of the brain parenchyma that is following. So that's a vein of Galen aneurysm. So we can see here again the secondary ventriculomegaly due to the effects of the vein of Galen aneurysm. It's an arterioventricular, it's an arteriovenous fistula. It's a high flow kind of structure. It's unfortunate I didn't attach the videos. We have some videos of the vein of Galen because I think we've seen quite a number now. So what it does is that it puts pressure, it causes high output cardiac failure on the baby. This is why the heart was enlarged in this case. And we see that there is heart strain from the ductus venosus, where the A wave was reduced for 36 weeks. So that's a vein of Galen aneurysm. And you see here, the big vein within the brain, all this is pulled with blood here. So the compression of the vein of Galen causes secondary ventriculomegaly, which causes a lot of destruction of the brain. So what happened to this patient? Unfortunately, the treatment for vein of Galen aneurysm involves embolization of the brain vessels to try and take care of the aneurysm. Available, we talked to the pediatric neurosurgeons, and they met the couple and expressed to the couple that it was not possible to do anything. The baby was delivered. We recommend that the baby came out because the baby was now going into heart failure. So we recommended for the baby to be delivered before the heart failure worsened. So the baby was delivered at 2.6 kgs, the same week that we saw the baby. Unfortunately, the baby demise in the next 2 days. While in ICU, there was very little that our neonatal team and the pediatric surgical team could do because of the vein of Galen aneurysm, what it does to the heart. And the only therapy there is embolization. And the moment the baby develops a cardiac failure in uterus, you really need some intricate neonatal care services to be able to resuscitate those babies out of it. More so if the primary cause of is too ongoing, like in this case, they say the vein of Galen is still there, is still giving high output cardiac failure. The maternal relief that was there is no longer there because the heart now has to do all the work. So the baby couldn't take it anymore, which was really sad. There is an association of vein of Galen aneurysm, which is in America there, which is trying to help people, but it's very complicated to get these couples to those centers. So yeah, so that was vein of Galen aneurysm. There are many other parameters that have to be assessed, but I think for the sake of our meeting, maybe I'll just stop here on the vein of Galen aneurysm. So the question now is, does it make a difference to know that this is secondary ventriculomegaly, secondary to vein of Galen? Yes, it does. You saw the outcome. If this was just a case of ventriculomegaly, the baby was not going to follow that outcome which I just described to you there. The baby was not going to develop cardiac failure because ventriculomegaly doesn't cause cardiac failure. So it is important to identify, to be able to distinguish between primary and secondary ventriculomegaly. It's just like missing that there is myelomeningocele, which is causing severe ventriculomegaly. All you do is pick up that there's severe ventriculomegaly. The outcome of these conditions is different. The baby with myelomeningocele probably has paraplegia, while the baby who just has primary ventriculomegaly may not have paraplegia, may walk. So all these difference, paraplegia and also failure to control the pee, failure to control the poo. So distinguishing the two conditions, primary and secondary ventriculomegaly, is very important in terms of baby outcome and also counseling of the parents. Because the parents have to have realistic expectations by the time they deliver, based on the good counseling that you have given them. So yeah, so I think in brief, these are the cases, two cases I wanted to discuss with you. We have lots of cases of fetal defects, both in the public sector and also in the private sector. Either we will ask you guys to present some cases you come across. If you do not have a case you wish to present, just let let us know. We'll give you. We have a library of abnormal cases. So if you want to present something and you feel you don't have a case you have identified or we have come across, but you feel like you want to just present and share with people, just get in touch and we'll give you the cases to present. Otherwise, our end here, vein of gallon aneurysm, I think we covered it when we did the neurology sessions. So you can just reference our notes there in terms of the vein of gallon aneurysm. Not very common, but I think to date, we have seen close to 5 cases. I'm not sure if we saw 2 in the private, 3 in the public sector, but yeah, I think we've seen plus 5 cases or more of this condition, vein of gallon aneurysm. So yeah. Do you have any questions on the case discussed so far? Any cases? So if we do not have any cases, any questions, I think we end here. Next week we'll probably do another case presentation, then we'll be just changing. But I think next week there will be another case. We'll find someone else to present a case, maybe 2 cases or so, depending on the size of the cases. But our desire is to present at least 2 to 3 cases per session. Otherwise, have a great day. Bye-bye.